Clinical depression treatments typically operate on a long-term delay. Standard therapies require a significant latency period, often taking weeks or even months before a patient notices a shift in mood. Subanesthetic ketamine acts on a different scale, often showing effects in hours or days. This latency is a byproduct of the monoamine hypothesis. For decades, psychiatry has targeted neurotransmitters like serotonin and dopamine, using daily pills to slowly adjust the chemical balance of the brain. But the failure rate is high. Roughly 60% of patients do not achieve total relief from SSRIs. Because of the onset delay, these patients often wait over a month just to discover the medication isn't working. Ketamine represents a pivot away from that model. Historically, it was classified as a dissociative anesthetic, used in high doses to induce unconsciousness for surgery. In the 1970s, it saw early clinical use treating trauma and PTSD in combat veterans, but was eventually sidelined by social stigma and recreational abuse. Its recent reemergence is driven by its speed. By providing relief for treatment-resistant depression and suicidality within a single day, it marks a departure from the multi-week requirements of monoamine therapy. Biologically, ketamine is defined as an NMDA receptor antagonist. In a healthy brain, the NMDA receptor acts as an AND gate for neuroplasticity. It opens only when specific chemical and electrical signals are present. This receptor is built to detect unusually high electrical activity. It is the trigger for memory formation and the structural rewiring necessary for learning. Recovering from severe depression requires this exact process of neuroplasticity. The brain must physically rebuild its connections to escape a depressed state. This creates a contradiction. Ketamine physically blocks the NMDA receptor. By introducing an antagonist to the brain's primary engine for growth, the drug should, in theory, lock the brain into its current depressed configuration. Other NMDA blockers, such as the Alzheimer's drug memantine, do not produce any antidepressant effects, despite having a similar mechanism of action. A compound that chemically disables the mechanism required for plasticity produces the fastest, most profound neural rewiring observed in clinical psychiatry. The brain maintains a baseline through a push-pull relationship between two cell types. Orange excitatory neurons stimulate activity, while smaller blue inhibitory neurons suppress it. These blue inhibitory neurons act as the braking system. They constantly release GABA to prevent the excitatory network from overfiring. Ketamine does not block all NMDA receptors with the same intensity. It shows a selective affinity. It preferentially binds to the NMDA receptors on the blue inhibitory neurons. This results in disinhibition. By blocking the inhibitor, ketamine removes the brain's braking system. With the brakes removed, the neighboring glutamate system undergoes an immediate, violent surge in activity. This is called burst firing. The excitatory neurons, now totally unshackled, begin to fire at an extreme, high-frequency rate. Ketamine doesn't stimulate the brain directly. It silences the silencers. It forces the system into an intense excitatory burst, which provides the necessary electrical signal to initiate a rewire. That electrical burst has a direct chemical consequence. The intensity of the firing forces neurons to release massive quantities of brain-derived neurotrophic factor, or BDNF. BDNF binds to TrkB receptors to initiate the physical growth of new dendritic connections.
It is the literal hardware of recovery. Ketamine may even accelerate this process by acting as a direct BDNF mimetic, binding straight to the TkB receptors itself. This cascade inserts new AMPA receptors into the cell surface. This increases the neuron's sensitivity, allowing it to function effectively without high metabolic strain. The brain has rapidly manufactured the physical hardware necessary to sustain new thoughts and behaviors. It is no longer stuck in the architecture of depression. We can now see how this works at a macro level. Two regions are critical here, the habenulia and the ventral tegmental area, or VTA. The habenulia functions as a disappointment circuit. In a depressed brain, it is hyperactive, suppressing dopamine and motivation. The VTA sits at the core of the reward pathway. It is the engine of motivation and positive anticipation. Chronic depression structurally reinforces an inhibitory pathway from the habenulia to the VTA. The brain becomes physically wired to prioritize disappointment over reward.
Ketamine-induced neuroplasticity actively weakens and prunes this specific inhibitory connection. By physically uncoupling the disappointment center from the reward center, the brain biologically restores a patient's capacity to feel motivation again. While the glutamate cascade explains the structural changes, clinical data shows that this is only half of the story. To test the drug's secondary mechanisms, Dr. Nolan Williams and his team at Stanford University Medical Center investigated these pathways through a specific clinical trial. They administered ketamine to patients, but pre-treated half of the group with a drug called naltrexone. Naltrexone is a mu-opioid receptor antagonist. It completely blocks the brain's opioid pathway, preventing any molecule from activating those receptors. The results were definitive. In patients where the opioid pathway was blocked by naltrexone, the antidepressant effects of ketamine were entirely erased. The recovery line remained flat. This points to how the drug is processed. Once inside the body, ketamine breaks down into a metabolite called hydroxynorketamine, or HNK. HNK acts on a secondary pathway, specifically targeting and binding to endogenous mu-opioid receptors. This proves that glutamate-driven plasticity alone is insufficient. Activating the opioid pathway is biologically mandatory to achieve durable relief from depression. Patients often describe the experience of ketamine as third-personing, a profound sense of dissociation where they feel separate from their physical body. This is a result of neocortical uncoupling. Alert alpha waves drop out, replaced by the deep, dreamlike rhythm of theta waves. The Stanford trial highlighted a final distinction. Naltrexone blocked the clinical relief, but it did not block the dissociation. Patients pre-treated with naltrexone still hallucinated and dissociated, even though their depression remained unchanged. The subjective trip and the structural relief were running on parallel, unconnected tracks. This confirms that the hallucinatory experience is biologically decoupled from the long-term structural durability of the treatment. Neuroplasticity simply creates a window of malleability. It biases the brain toward change, but it does not guarantee it. Ketamine does not cure depression in a vacuum. It uses dual glutamate and opioid pathways to force open a structural window, relying on the patient to wire antidepressive behaviors into their newly remodeled brain.